Well, hello, welcome to the Institute of Health and Social Care Management. This is our integrated care special interest group, and today I'm absolutely delighted to be welcoming two stalwarts of the Institute. We have the one and only Craig Oates from Doctrin, and we have Elaine O'Brien from what was Cerner, but is now Oracle Cerner Health. I think that's the way we pronounce it these days, Elaine. The topic of conversation today is all about how we prepare patients for home care. We were to be joined by Dr. Nadia Correia as well, who's a clinical director for an ICS, but unfortunately she's been called away to her daughter's nursery because of an incident. Read into that what you will. So we've got Craig and Elaine, and I'll be trying to facilitate matters as well. Do feel free to put your virtual hands up if you're in the audience to ask questions and so on as we go along, or to make comment or opinion. We'd welcome that. We'll see how we go. Craig, would you like to introduce yourself, first of all, more fully than perhaps I've done?
I can. So my name's Craig Oates. I look after Doctrin, which is a Swedish e-health company, and I look after the UK and international growth. And previously I had a number of roles, both at the department, leading a PCT in the long distant past, and also in acute and other care and advising others, and previously head of e-health for Accenture.
Perfect. Thank you very much.
Sat in the car park.
Yes, sat in the car park on the motorway services. That is a measure of Craig's dedication to the cause. Elaine, would you like to do the same, please?
Hi there, everybody. My name's Elaine O'Brien, and I work at Oracle Health, as John just mentioned earlier. So we're a international, or a global company, originated out of the US, but from my point of view, I work in the health part, but our company generally works in a number of other areas around communications, construction and engineering, and energy and water, finance, and many other aspects of other public sectors and local government. And the reason I call that out is the opportunity to bring the experience and technologies that sit in that space into healthcare, because they can help with disrupting how we operate care pathways as a result of that as well. So here we go.
Thank you, Elaine. Right, well, look, let's get straight into this. So basically, what we're trying to map out here, or seek advice from Craig and Elaine on, is how we prepare patients for discharge to be looked after in their own homes, and perhaps what criteria we ought to be looking at. So, Craig, may I begin with you? In your experience, how do we even start to prepare ourselves for looking after somebody in their own home environment? What are some of the golden tickets that we look at first of all?
Well, I'd say in my own experience, both in commissioning and provision, it's variable within organisations, particularly variable, say, within surgery and medicine. But the most important thing is the patient safe at home? And I think that's been a huge challenge around certainly medical discharge. Can they be supported? And if something goes wrong, we often, look at the worst case scenario and hold people in, which has all the challenges of discharge. We have a social care component of not having safe places to discharge people that aren't at home. And we also have historically a huge lack of integrated care within organisations, never mind across, where it's best, where you have multidisciplinary team working with the patients, their family and social care colleagues to make a seamless assessment of discharge, absolutely brilliant. In other places, you have people stay months longer in hospitals, which, as we know, are not good places to stay.
All right, that's a helpful start. Elaine, would you like to add any hundreds and thousands on top of Craig's initial ice cream cornet?
So I think, so we work or have historically worked mainly in the acute sector, and more recently in the bringing together the multiple other providers that sit outside of the acute. And one of my observations is the level of risk management and the risk management tolerance. So when you work in the acute sector, there's much less risk tolerance. And when you work with a GP or primary care, the tolerance for risk is much higher because there's a greater understanding of the impact of families, neighbours and communities on the scaffolding and support of that individual so that they stay in their place of whether that be their home or their care home. And it is understandable why acute clinicians and operational managers do not understand that in the acute, because that's not what they're exposed to and they don't see that. But it's a bringing together of that information and confidence and growing relationships with those other parties that I think is the missing part and is helpful in developing that. So we improve that confidence of the acute clinical teams to allow patients to go home at a much earlier stage.
Perfect, thank you. Craig, I'm going to come to you next, and you can have as long or as short an answer to this one as you like. But again, based on your experience, what sort of a team do we need to assemble by way of creating a decision about whether a patient can be effectively discharged to be looked after in their own home? We know this goes beyond the acute consultant who might be saying, right, they're ready to be discharged now. Talk to us about how we assemble this full team of people who can actually make an informed decision that somebody can now be discharged and can be looked after in their own home.
But I think I step back from a single team, because actually to have having a full personal assessment of every patient is going to be more of a blocker than care beds, to be honest. I think what we picked up on is it's about risk management, and everyone in that team, that multi-risk team of primary care, secondary care, social care, third sector, family, and most importantly the patient, have confidence that there are protocols and systems and ways of working in place that manage and mitigate risk. So if I had medics when I was at Leicester who, I'd like to keep John in for another 3 days, and I'm going, well, I want him out of bed because I've got people sat in A&E. And yet I could send my surgeons around who might take a 2 risk positive discharge policy. So I think some of it is about taking the personal out when ensuring the professionalism, rigor and metrics are in place. Actually, for John, with the challenges and issues they have or the support they need, the scaffolding, I think it's a really good phrase, do we have it in place? And then trusting that system. And we've had discharge teams and community matrons and everything in place, but we don't seem to have had the consistency or trust or confidence. And that's often the confidence of the patient or the family, but typically they will trust the medical team. But
all right, sorry to interrupt, Craig, but just help me understand, how do we do this? Because you are not going to be able to assemble everybody in one room from across social care, community, nursing. It's just completely impossible to do that. Absolutely. So how do we get this decision-making process effective and in a timely manner? You don't want to be sending emails across the place and just endless kind of weeks of email. How do you do it, Craig?
So we know there is best and excellent practice out there. We do what the NHS has done well when it works its best, is take the best and share. But what we need to do is tie that into training and trust, but also, and I would say, it's technology. So one of the things we worry about is when we discharge them at home, we can't monitor them, they're not being checked. What happens if things go wrong? If we do give them what are now relatively cheap wearables and other devices that they and their family have confidence in, doctors have confidence in, we can discharge using Cerner and Epic and other platforms to use analytics to drive that assessment and not have to send emails. People do their job and fill in the EMR, it's good, but also giving them a package of care that doesn't just mean someone visiting you each day, etc. So a really good example I'll give you in the Basque region and Valencia, actually, they had real challenges with patient discharge and getting people out because of these issues. So what they did, they set up a team, a series of teams with a doctor, a nurse, and a therapist, and access to other services. Everyone who was assessed as high risk was discharged, the same as everybody else. They got a phone call on day 1. They got a visit on day 2. They got a phone call day 3, day 4, and a visit day 5. And if there was an issue, they'd say, yeah, I know you're in agony. You had your hip replaced. Are you taking a tablet? They would manage and mitigate the patient. The other side, if something was wrong, you had a team who had the car in the car park, all kitted with whatever they needed. And as long as it wasn't a blue light service, they went out. So they used analytics to identify the patients most at risk. So you don't risk manage by cohort. You can effectively manage by individual, which is the only way to do it.
Yeah, so what I'm trying to sorry to interrupt, Chris, it's just tricky when we're doing this virtually, otherwise I'd just be chatting to you. But what's the process by which all of these different decision maker components are enabled to see information about a particular individual so that they can all make, in a timely and effective manner, a decision about should this person even be discharged into their own home? Have you used a particular technique or a device?
Well, there are lots of devices, but the chief area is sharing that record in a system that works. And if we look at Vision, with their Vision Anywhere product they're rolling out, that enables it. We have other products and companies with whole system records, portals. Imagine a jigsaw set with excellent technologies, but it needs to be brought together. The challenge we have System 1 and EMIS or Vision in primary care. We have secondary care systems, not always that talk to each other, but don't work together in terms of a patient journey. And social care isn't even in there. So I think this is for me the key role of ICB. We know the best practice. We know the systems are already in place in the landscape. Commissioning services that allow you to bring that data together. Forcing those data sharing agreements through if you need to, as long as they're safe and effective. But most importantly, local ownership, but speedy decision making. This can't be done, as you said, it can't be done by large committees for an individual patient, nor can it be done by large committees to set up these protocols and processes. Get some experts together and trust them, and don't be bothered about plagiarising what's best elsewhere in the UK and everywhere else.
Yeah, I'm going to come to you now, Elaine. Actually, please elaborate on what Craig. I'm just looking at what Fran has said in the chat. She says, seems to me that the basic foundation resides in GP record and it's accurate or missing patient profile. Disability registration often missing. People without any social support are not flagged. Makes it difficult for acute care teams to properly plan discharges, let alone imagine issues of harm. That's kind of what I'm trying to get at here. How do we, what system, what process have we got available to us that people on this call might be looking at thinking, now that's a good idea, how we assemble the information. What do you think, Elaine?
So I think what I wanted to say is that what I'm going to say next is on the back of the learning from COVID. So COVID drove organizations to communicate and engage with clients through virtual platforms, so whether they be patient portals or whatever they may be. And that's the bit that has allowed other organizations, mainly acutes at this point, to build out on the back of their electronic record the concept of virtual wards. So you build a part of the record that allows you to give access to other providers, to a group of patients that have to be discharged or about to be discharged. So multidisciplinary teams from multiple provider organizations can work on them and manage those patients. And I'd like to say that we're focusing on discharge, but actually we need to also focus with the same methodology to work on admission prevention.
Yeah.
So occasionally, or not occasionally, quite a lot of the time, you can manage people down to remain in their home, to reduce that crisis or reduce it back into their manageable position, because patients and families deal with really complex problems at home all of the time, particularly when you've got patients with very multiple conditions and very complex conditions like COPD. So those are the things that we're seeing in practice. So building out a ward that looks after respiratory patients, building out a virtual ward that looks after post-surgery patients, so it might be knees, hips, whatever it is, and creating that environment for people, for professionals to work together. In addition to that, to ensure we bring all the other pieces in, so you need the list, which is the virtual ward, then you need the technology where they're able to collaborate virtually, which is the kind of, what we're doing today, Zoom call or Microsoft Teams, whatever it may be. And then the third and most important bit, I think, is about the communication process with the person, patient, family. And that's the other piece of technology that's allowing that to happen through patient portal. And sometimes it's basically lifting a phone up and having a chat with the patient. So it's either the data coming in via those technologies, or for those patients that are not able to do it, because not everybody has access or is able to do that, it's the traditional having a phone call with the patient or a visit, whatever it might be.
Who should be the ultimate arbiter, Elaine?
Well, I think there's two bits to it. So I talked about admission prevention and discharge.
Well, let's talk about discharge now specifically, because we're going to be moving on to the home care process in a minute.
Right. So
who should be the ultimate arbiter of yes or no?
As in making the decision whether that person is discharged.
Right.
Well, so this is where we create grey space, and technology is driving that grey space. So I think my personal experience of that is it depends on how the protocols and procedures are set up. We shouldn't be caught up with a virtual ward sitting on an electronic record that is the acutes, or an electronic record that's primary care. It's somebody aside from the technology has to set up the processes of accountability and responsibility. So in one area, it might be a joint appointment with a GP and the acute, be employed by the acute. It might be the acute physician, or it could be a combination. It depends on how that local community operates together and the relationships that they build together or have already built, because these exist before digital applies. So there are paper virtual wards now in some areas where digital does not exist. And you have the roles and responsibilities are divvied out depending on the appetite of that local community. All
right, Craig, you know what's missing there? The patient or their carer or their family, who are going to be the people ultimately, who are ultimately going to be the people who have to deal with this, So how do we get them involved? They're not going to have access to these various systems and so on, I would imagine. How do we get them properly involved in this?
I think Paul picks up a good comment as well. Pick up to about how does the patient have confidence in it? So if I've got my dad says he has in Blackpool to get the best service in the world. Here he has a Correia matron comes visits him every month. He says they visit to me too often. He has confidence. Now what we haven't tested yet, which is Paul has picked up, if there is something wrong, how fast can he get back in to be treated? And so I think there is something around ongoing management by the right professional. And I think that's why it shouldn't be a remote discharge team or somebody else. It should be someone in that community who is responsible for that patient, their family, be that a care navigator, be that an AMP, if they have more immediate needs, be that care, but a single point of contact that the family can trust. So the family and patients, to my mind, and looking at my dad and my mum, is I want to have confidence someone's making safe decisions for my parents, because I want to trust them. I want to know they're being monitored safely and effectively in a way that they're comfortable with. I talk to my dad about Doctrin, and he thinks I'm the devil incarnate. He wants people. He's 92. He doesn't want technology. It's about having the right blend for the person, and most importantly, confidence that if things do go wrong, I can be brought back into the old step up, step down service. So absolutely the patient needs to be involved and their family needs to be involved, particularly in that dialogue if the patient, if part of their care package is going to be support by the family. But the key bit is, to my mind, and that's in hospital and in primary care where I've worked in both, it's having communications and honesty and transparency. And for a patient, I can get through to someone when I need to and know I'll be treated. So there's a big, to me, it's communications and trust, and we have a long way to go, I think, in some areas to rebuild that.
All right, I'm going to give you both the opportunity to have a bit of a think about this. So I'm going to give you the conflict, I'm going to kind of pad this out a little bit while you think. If we didn't have what we have today in terms of all the inconsistent structures and all the rest of it, all around the country, varying from community to community, and you could plan this from scratch in 2023 using all of the different technologies now at our disposal, how would you design this from blue sky if you were absolutely focused on make this right for the patient above all, and make this right for the patient's carer and or family? How would you design this up today if you were given the opportunity to kind of move aside all of the existing, some of them archaic structures? The reason I'm padding this out is I want to give you both the opportunity to have a serious think about it, because many of the people on the call now will have either had personal experience or they will know of people who've had the most appalling experiences of discharge and home care and so on, where they've simply not been consulted. It's all gone wrong, and the patient is inconvenienced at best. But I'm going to, while you two have a think about it, I can see Paul's got his hand up. So Paul, would you like to come in and just make your observation? Thank you.
Yeah, thanks very much, John. Really interesting. I think it was slightly unfair, if I can be bold, for you to ask who's the arbiter, because that's quite a complex thing when it comes to discharge, isn't it? Because it's not just a health thing, it's not a social care thing, and it's not a care provider thing.
Well, let me. Okay, I don't think it is a complex question. I think it has to be the patient should be the arbiter.
Well, that's an interesting conundrum presented, because if a patient does not want to leave hospital, or their family have deliberately gone abroad on holiday to God knows where, and they're away for 3 months, what happens then? Is it the patient's decision? I beg to differ. That happens with far greater regularity than people believe. Yeah. Yes, patient. Absolutely patient. I can give you some cracking examples where health and social care have agreed to discharge on Friday, ready for a Monday. And then come Monday, health have already discharged the patient to a location that they didn't agree on. And the patient is totally confused. The family don't know where the patient is, their relative is. So it is complex. It's a fair question, but you can spin it any way you want to. Long and short of it is, you're right, EPR shouldn't manage these things, because EPR is a silo-centric, clinically focused system. You need something, a blue sky. This is exactly what we've been working on for nearly a decade now, about having an interface for the patient and their family, an interface that works for social care, and an interface that works for health, and it's all one and the same thing. So nobody can have, let's say, cross communications. Nobody can say, oh, I wasn't aware. If you want to go technology, go real time. The moment one person does something, everybody knows about it. And I mean literally everybody, in less than 5 milliseconds. That's
okay.
my
Thank you very much. And having padded all of that out now perfectly, I'm going to let's go to Craig first of all, and then I'm going to come to Elaine with your answers to that original question, please.
Well, you give me the easy one again. So I think
so. Just to remind you, this is about if you were going to be given the opportunity to design this from scratch and have this adopted as best practice right across England or Wales or Scotland, Northern Ireland, how would you do it? What would you have in place?
So the first thing I do is I look at this from the patient journey, irrespective of organisation. When we put organisations to mix, that mucks it all up because we're up systems, we're what data. So actually, you know, the 80-20 rule, what is for that pathway the best way of managing that patient journey from the when they're identified, and not only at discharge, but their ongoing care and case management, hopefully through to great quality of life, or in other cases to end of life. And then we look at, you know, get your old swim lanes out. There's some fantastic tools you can do that electronically. Who gets involved where, and what information do you need? So actually, we know the best patient journey. I think what does get in the way is it's our organisational focus and the fact all the information's there that mixed up. So let's start, where do you want to be? Stephen Covey, begin with the end in mind and work back. And I think that's the way to do it, that we know the right way of doing it. We sometimes focus too much on where we're coming from. Let's start where we need to be. What do we need to change? What information do we need to make that happen? It's a very glib answer, I know, but actually bringing the same old people into the same old room, we're going to get the same old thing. So actually getting brown paper up on the walls and the virtual equivalent, say, right, for a patient coming in for a hip replacement, who's fragile, are they fragile, are they not? Do they have support, do they not? But actually focus on that patient journey, and more importantly, what evidence is there of what outcomes are driven by. So in theatres, we worked out at Leicester that actually warming patients as they were coming out from theatre reduced their stay maybe by 2 days. So what are the evidence of the points of excellence across that journey that we need to engineer in from the start? So for the best patient journey, what do we do? Then we look at what analytics can help us identify that. What data points do we need? And what system allows all the different stakeholders, patients, clinicians, others, to actually see what they need? As Paul said, the key, something that made a real difference on wards, was the named nurse. Who's the named care lead for that individual? I don't care what organisation there is, because it will vary by that patient's needs. But actually, they have one phone number or one digital access they can go to and just go, it's gone wrong today, what do I do?
Perfect. All right, I'm going to give Elaine the opportunity to have her insights. Go on, Elaine.
Well, I think if I were to pull out the flaw that I would see in how we design things today is around the focus on the provider as opposed to the person who needs the care and support. You know, I'm going to look at the area that I work in. Is we have in the past designed electronic systems thinking about servicing the physician, servicing the nurse, servicing the social care provider. That's the way to go about it. And, you know, we will put our hands up around that. It's what does the person who needs care, whether that be detection, prevention, or management of a disease or a process like a knee replacement or whatever it might be, that's the bit that I would change. And with that in mind, then we have a health and care record as opposed to a acute provider record, a GP record. I mean, who cares? We just need to sort that patient out, so that person out. And I'm going to say person, because not all, the majority of our healthcare is as a person, not as a patient. So I know that's quite off the topic of discharge, but if that was
I rather like that. So what you're saying is do away with all of these different records and have a health and care record for each individual that genuinely brings everything together.
That's the blue sky thinking. Then you have to come to the real world, and then you have to work where we are in the real world, which is what it means then. It's about connecting all of the information from those records and being in what the term in the industry is interoperable. And what that actually means is being able to transfer or hold the data in a central place to create that single record. of that individual person, and then manage from that rather than multiple electronic systems.
Okay, thank you very much for that. Can we move on now? Let's say, right, the person is now in their home, they've been discharged, and we're now trying to look after them as best that we can. Help us understand, or help me understand, what are the priorities here? How do we, I'm guessing you're going to be talking about monitoring. We're going to be talking about access to care if something starts to go wrong based on that monitoring, and then the speed and efficiency with which that care can be delivered based on that monitoring. Can you give us any insight? Craig, would you like to start there?
Yeah, so I'll go back 15 years, and this is the Basque region. So they did all the predictive analytics stuff around chronic disease, particularly what was happening to patients, getting them discharged much quickly, quality of care, quality of intervention. But what they then did, they put Microsoft Xboxes in those old people's homes, and they had wearables attached to them. They had videos on there of the exercise they could mirror and do every day. Now, I'm not saying it was perfect, but technology has moved on so much now. That's what you want. You're absolutely monitoring, but monitoring that's not invasive. We have some apps now that wear in pocket, and they, from your walk, how you walk and gait, it can determine if you have a health issue. Some of the ways we monitor care now are not about sphygmometers and blood tests. They are so advanced, it's scary. So I think the monitoring is very different, and we have technologies that can do that in a less invasive way. Because part of this is not tying the patient to their home because they feel they can never leave, because that's where all their scaffolding is. We want the scaffolding to walk with them.
Okay, so may I just ask about who's looking at this wearables data? Who's accessing this?
So in many cases, it's the virtual ward technology organisations, so Spirit and others. They will have that technology, but typically it's in really cool apps that no one's using for anything else. And if you take those bits of that technology and actually join them together with that health and social care record, wow.
No, what I'm trying to drive at is who is accessing this information.
So in that,
is this a, so when we've discharged people to their home, there they are, we've got multiple agencies potentially involved. We've probably got the tertiary sector involved. We will certainly have primary care involved, and we'll have the acute from where they've been discharged involved, I'm guessing. We've probably got consultants involved, and we will certainly have nursing staff involved overseeing. Who is monitoring all of this wearable data so that actually the right decisions are being made at the right time? Because otherwise it's just wearables for wearables' sake, isn't it?
So I take all that lot out of the equation. They're the second line support. What you want is, if we look at our Basque region example, they had a contact centre team at Valencia, had a small team of physicians. Their only job was to support those patients in their home and to be their advocates within the service.
Right. So what you're saying is we need a monitoring centre, a control centre, for want of a better word, where the data is being constantly monitored, and then depending on what the data says, specific agencies are then being contacted to interact. Is that about right?
I'd say it's more than a monitoring centre. It's more than about the data. It's about having a level of clinical capability that you can be an advocate. You don't need to be a consultant. You can be a physician's assistant. You can be an AMP, and I know how hard those are to group it. You can be a care navigator. Someone who is getting the alerts that the technology will monitor. The monitoring is done by technology. That's giving the alert to someone who can then look at the record, understand that patient, understand the narrative around that patient and what their support network, and is that phoning their son John, say, we think your dad's having a bad day, do you want to give him a ring? So the other is, actually, we'd really like hospital, we need to bring John in. We think his stats are all over the place. We want to bring him in for monitoring, or we want to bring him in to have his pacemaker reset, whatever it might be.
Yeah, I get this. I'm just trying to figure out. I'm just trying to figure out where the responsibility lies for this. All right, look, it's fine. I'm going to come to Elaine. Elaine, I'm very eager to get your insight into this from Oracle's perspective.
Well, I think so there are processes in place and they're all siloed. So, and they're all people power heavy. So yes, the centers where all of those applications are monitored for the alerts by humans are definitely in place. The next step for that and the critical factor for scaling things up and reducing costs and improving efficiency is bringing the core parts of that data get into the electronic record, whether that be a health or whatever we want to call it, but into the central electronic record. And then that drives decision making from there, which is a completely automated process that can trigger whatever that might be, a person engagement or a kind of a process to look at what the next steps of care can be. So that can be fed back to the patient and their family if those things are set up in place, but they are not in place right now. So it's kind of the next phase of taking those technologies and driving them through algorithms to get the next phase and remove that level of resource input that is currently sat around the country.
Because what you see, there is, remember where we are. This is the Integrated Care Special Interest Group. Yeah. So it's this. How do we enable all of these participants in integrated care to sensibly and effectively interact with the care receiver, the patient or their families? Yeah. And that's the bit that I'm still I'm just not certain what we're advocating here. How do we make this multidisciplinary integrated approach work? I get it from the point of view of the acute care coordinator is able to see it and interact. What about all the others? What about people, I don't know, British Red Cross, for example, who might be responsible for popping round? Yeah. What about a social care volunteering organisation from their local church or community group who might be involved with that particular individual? And that's the bit that, if we make it too acute centric, that's the bit that we lose somehow. Yeah. I'm just really interested in whether you've got any observations or examples where, this has been enabled more fully than is currently the case, perhaps.
I think you've picked up exactly the key bit there. The acute episode is an episode of care. It is not the journey. And so actually, as you say, the majority of care is delivered by other agencies. Now, we do have new roles, care navigators, and some of those are brilliant. Those who actually know what's happening and who to reach into. So a great example I saw was I was watching someone talk to an individual who had a mental health crisis using Doctrin. Doesn't matter what they were using. And they said, right, well, we've got some things we can do for you now around some therapies, some pharmaceutical interventions, but actually what's driving your issue is debt. So what I'm also doing is I'm referring you to our third sector debt management partner who's going to help dealing with the underlying issue here. Nothing to do with health, nothing to do with social care. It was actually the underlying issue is you're ready to kill yourself because of what's happening with money. So we'll stabilize you. We'll do that in acute intervention, wherever it is, but actually bring the right person in. And that's what makes that's the bit for me. But you need someone who understands that network. GPs don't understand the primary care, what else is out there. Acute physicians and acute management certainly don't. Commissioners try, we struggle. Care navigators are the ones who know what's available at locality and what isn't. And I think that's the role that I was really excited when I saw it come out, that care navigators are the ones who can own this. Because we want the physicians, the clinicians, the caregivers to focus on care, not being the arbitrator, negotiator, arranger of the wider care setting. So the care navigator for me is the hub of where this sits.
All right. Let me ask a supplementary question then. So we've got a care navigator. who pays for this integrated approach then? Where does the budget sit for looking after this person in their own home?
Out the ICB budget, because if we're looking at 70% of spend being spent on that 17% of the population with long-term chronic issues, and they're expensive because they're having to come into hospitals for high-cost interventions, it will pay for itself probably quite quickly, because we won't have people coming in for multiple long stays and going from level 3 to level 5 of the Kaiser Permanente Triangle in no time at all. I think that's the bit for me, is this has to be invested in because there will be long-term benefit. And I think that's one of the challenges we've got, is we get these long-term investments, and I was in finance at the department one time, I was as bad to blame as them, is a long-term investment, but actually we don't stick with it. The money gets drawn to something else, or it's now in your baseline. We need to hold our ICBs to account to make those longer medium-term investments across the care system, but make sure the savings come in and aren't just lost, because otherwise...
All right, so have we, so I know we might need to, have we got any, Elaine, have you got any examples where this is in place and it's working well from a genuinely integrated perspective?
Well, I think the what you were sharing was about funding of this. Is that...
I went on to funding. Yeah.
Yeah, and I think that kind of comes from the siloed provider process that's in place at the moment. Yeah. And I don't see the ICB board funding this. I have a different view on that. I think it's a provider collaborative is the ones that are obligated to do this and to change how they work. But in practice, that's not what I'm seeing. I still see providers working on their own part because they're not incentivized to do so. Mm. So I don't know if you know about the 4 I's for the population health management. It's infrastructure, intelligence, intervention, and incentives, which has been changed to impact. But we've got the first 3, and lots of places are doing a really good job of that. But the loop hasn't been closed because, let's face it, we all have to work with money, even though we are public, these are public sector organisations, and you have to close the loop on money. And that is fundamentally the problem that stops organisations developing past 1 or 2 years. And until that's integrated, as the ambition is to integrate care, having an integrated funding approach, we really are not going to move that far. Yeah.
Well, I was going to ask if you knew, typically who employs the care navigators, and I'm speculating it's probably the acute hospital.
No, we're seeing combinations of things of that.
We are. Good. I'm relieved to hear that. Thank goodness. Okay.
Yeah, but it's primary
roles. Yeah, they're
say again, please, Craig.
So you have primary care network IHS roles. They're a specific funded IHS role, but you also have. So I'm a non-exec of a addiction charity in Derbyshire called DAS, and the service they're commissioned to with other providers is ongoing care for addiction, and that includes counselling, CBT, support. So a service is commissioned like any other service. One of the challenges I think you were picking up is, if I look back when we set up years ago primary care trusts, there was a facility then for health and social care to work closely together. And I remember sitting in a discussion where we had a new drug for Alzheimer's that we believe could be a huge intervention, increase quality of life, reduce the cost of ongoing care. And the struggle was, we had a health authority in those days going, yeah, that's great, but that's actually going to cost us a load of money for that drug and all the benefits in social care. So why would we do that? And I sometimes think we still have that type of, that's why I'm saying we need to commission a service, and maybe not use the term providers because it's wider than that, but commission a service from various stakeholders where there's a budget, where there's a fund they deliver. Because otherwise, the challenge we have is, well, all these interventions are going to cost me as a trust. It's not on my tariff. And
no, well, this is what I'm trying to get at. That I'm hearing. Wouldn't it be nice if? I'm trying to find now Right. So have we got any examples of where this is working perfectly in the country, regionally, locally? Don't really mind. Have you got either of you got anything you could point at and say, John, or anybody on, in our audience here? I'm suspecting that a number of members of the audience are keen to find out more because either they're a student of this or they're a practitioner who's looking to introduce a better system in their own area. Is there anywhere we could point at and say, go there? And I am talking England, Wales, Scotland, or Northern Ireland. I'd love to pop along to Valencia, but I don't think it's necessarily practical right now.
And I don't know.
Have we got any examples?
For which bit? The developing, working with.
So where's this working well on a genuinely integrated basis, so that patients are reassured and confident that they are going to be getting the kind of support and monitoring that will enable this home care idea to be genuinely effective?
So the example that I would pull out is what is being done with Imperial, where they have, and I don't think you got to that exact bit you're talking about, but it's a step towards it, where they have built out the virtual wards, which I spoke about at the beginning, and built a team of people around to operate the requirements of those people within the virtual wards. Now,
and that's a multidisciplinary integrated team, yeah?
Well, I think that might be taking it a little far.
Okay.
But it's a step towards that, getting to that space. And I think because it is, I mean, this is a really big, long journey. And I think that, we do that, there are steps, but I don't know that anyone's cracked it all. But I think the bit that comes out of that for me, it's not just about the process, it's about how people operate. Because looking after a ward full of 200 people virtually is extraordinarily different than looking after a ward full of 30 patients.
Yep.
And that.
And PS, it's not cheaper or easier or anything like that either, if you do it properly.
Well, I mean, I think you need to look in the round. You have a person at home who is then no longer susceptible to the issues about being hospitalized, the reduction of infection, mobility, the risk of, so there's, I mean, it depends where you're measuring from and what you decide is cost, good value for money. But it's the speed and risk that those workforce members have to take on that is actually very, very different. And you're asking a nurse, doctor, physio, social worker, whatever profession they are, to actually work in a very different way. They probably went into the profession to sit beside another human, hold their hand, have a very personal conversation with them. And suddenly you're working at literally at a computer, looking at a dashboard and potentially ringing them if there's a problem, and maybe not ringing that many people or having that conversation. So that cultural shift for an individual, a professional, a group of people who've worked probably in an acute multidisciplinary team together, and suddenly you're pushing them and saying, let's work as a virtual team, and we never actually may see each other, whether that be on Zoom or, in
I get it. I'm just trying to find out, where do we go to see? So we've got an example of Imperial who are going some way towards this. Craig, have you got any examples?
I haven't got an example of where it's worked across the board, but there are examples in pathways. So end of life care, there are some areas of the country doing really well. I think Calderdale's one of those. My understanding, talked to a couple of GPs in that area. We have some care homes who've been really leading the way on this around virtual wards and virtual management. I need to go in, dig into my notebook and find some examples and I can share them. But no, I'm not aware of somewhere that's got that whole place service, but I am aware of parts where they're working really well in particular. And maybe that's it. Maybe actually we do look at the more challenging pathways, prove the concept, and then grow from there, because you say it's a pretty big step to set up a whole new service, totally change your commissioning and say go for it. Some people are up for it, but if I'm looking at trust where I'm getting beaten senseless because my UTC isn't delivering and my wait lists are up the hoo-ha, this is just noise I'm not interested in. So
no, I get it, because it's all the here and now. It's all the here and now. But we've had the ICBs in.
NHS England need to drive this, and the other side is CQC need to be underlaying it.
Oh,
so if CQC are nicer, they're saying this is evidence-based, high quality, and we will assure it as CQC. I think that takes a lot of the worry away. Whether depend on you.
All right, I'm going to have to cut you off because we've got Craig, please, enough. We've got 7 minutes left. I'm going to open this up to the audience. We've got a bit of chat going on, but audience, anybody like to ask a question of Elaine or Craig, or make an opinion or an observation here based on your own experience? This is your opportunity. Please put your virtual hand up if you would like to ask or make an observation. I think we've got some students on, I suspect, from Arden today. What do you guys think? Where would you take this from a student perspective? Just while you have a think, I can see Paul's got his hand up. Over to you, Paul.
Thanks, John. And I don't want to hog this, but I think historically the approach around EPR and about patient record is fundamentally flawed. I know that must sound quite bold of me, but interventions, yes, go in the clinical record. Scheduling things that haven't happened yet have no part to be in the patient record whatsoever. And therefore, this paradigm shift, a new approach, it's refreshing to hear Elaine and Craig speak. Would like to speak in depth with them. There are better approaches. Trusts have no incentive or interest in looking at the broader picture, and as my note has said, the ICBs are directed and funded by NHS England. It is almost impossible for them not to take a clinically biased perspective on this. So perhaps, again, a fundamental shift in that area might also help.
Okay, thank you very much. Anybody else like to make an observation or ask a question? Okay, well, what do you might be wondering, what do I take away from this? I take away from this that we have an imperfect vision at the moment of how this should work. We have not evolved this as fully and effectively as perhaps we might have wanted to do so, given all of the noise that is around home care and virtual wards. And I suspect we're still quite acutely biased in respect of how we're trying to design this. So we're trying to design this is how does the hospital, in inverted commas, please don't quote me on this, get rid of this patient, rather than thinking about what's the best thing that needs to happen for this individual and then for our health system and care system. So I'm leaving this with more questions than I started with, in a sense, which isn't terribly perfect, but at least we're discussing it, and out of discussion comes solution. So that's where I get to with it. Anybody else differ from me here?
Well,
I like that, Oliver. I think that's right. Oliver just says, I think there's a lot of potential in this, but as John says, it needs a sharper vision and cross-organisational buy-in. Get that, Oliver. Thank you. Elaine, sorry.
I think that's why I was nudging towards the prevention of admissions at the beginning.
Yeah.
Because they're either side of the coin, right? Because it's actually always much better if we go to the left and not have people in hospital in the first place, for many different reasons.
Well, maybe that's the next thing. Maybe that's the next thing we should do. Maybe we should, as the Institute and through the Integrated Care Special Interest Group, maybe we should design a vision for how this needs to look, and then challenge people to say, right, how are you going to make this work?
Yeah.
Maybe that's a nice way for us to go forward, you know?
One thing that might be interesting is we have one ICS chief executive who's a GP, who took an incredibly radical view of GPs in the future. And I think that's where the change will come. It's from people leading those ICSs who think differently. And the acute problem is getting rid of the patient. I was an acute director, absolutely. I've done my bit. I needed to go somewhere else. We need someone who own the ongoing challenge. And I think that's where you'll see some individuals, not just GPs, but others, those are the key for me. Because as an acute director, I just needed you out of my bed.
Yeah. Okay. Thank you. Paul Batchelor's got his hand up. Hello, Paul. Nice to have you with us. Would you like to come in? You are on mute, Paul. As you always are.
That's a fiver. That's a fiver I owe you. Yes.
I wish you'd come on every single one of these, because I would be a rich man by now on the basis of the fines with you.
Yeah.
Go on.
Just that we're discussing an acute sector problem. You know, the whole debate around health care remains focused on the acute sector. And until you engage with, first of all, if it is a health treatment issue, then you've got to involve the primary care. And if it's about determining health, that's even wider than that. And it just strikes me as bizarre. We're trying to say we've got an acute sector problem. You know, for example, why have we got so many hospitals in London compared to other areas? A historical problem where no one's confronted that issue. And we have to deal with the acute sector and get it focused and say, this is about dealing with the managing care, somebody's journey, and it's not just the.
We only have about 30 seconds left, Paul. So
there we are. I'll stop at that point then.
Magic. Thank you very much indeed. All right, look, we are running out of time. I do hope you've enjoyed that. I found it useful. My huge thanks to Elaine and Craig, who've given up their Friday lunchtime to come and chat to us and give their perspective. We're most grateful to both of you, and thank you in the audience for your participation and interest in this. I have a funny feeling this integrated care special interest group is going to have a little bit of a further look at this, but maybe we get to design what the vision of this should be and then challenge the various different sectors to fulfill the vision. That might be interesting. All right, but for today, have a super weekend, all of you. We'll see you next time. Bye bye.